cancer. In gynecological malignancy, endometrial cancer, in spite of very good prognosis in early stage, has increased mortality as well as incidence in India as well as in all the world. And this is the sixth most common malignancy in the women's. And incidence in India is approximately 4.3 per lakh women. And the prognosis is very good in early stage, approximately 95%. But in stage 4, as well as in the recurrent endometrial cancer, prognosis is bad. It is less than 20% in 5-year survival rate. So in early days, we will divide endometrial cancer only on pathological and clinical criteria. And we divide in two parts. First is the type 1 endometrial cancer, which is more common and has a good prognosis and low-grade tumor, which is estrogen dependent, while another one is the type 2 endometrial cancer, which includes mixed type of histopathology like clear cell carcinoma, serous type, sarcomatoid type endometrial carcinoma, and it is not as non-estrogen dependent and has a poor prognosis. But depending upon these, our treatment is only hormonal therapy to low-grade tumors and chemotherapy for the high-grade tumors in recurrent and stage 4, and the prognosis is not much good. But in modern era, we have a molecular classification for endometrial cancer, and the Cancer Genomic Atlas classification, which divides endometrial cancer on various molecular markers into four types. First one is the pole E, in which it is a hypermutated stage. It is approximately 5% of the all endometrial cancer, in which there are so much mutations in this type of cancer, and there is exonuclease domain mutation in pole E type, and it has the good prognosis. It is the most favorable prognosis in endometrial cancer. Second one is the MSI high, in which the microsatellite instability, in which there are various type of mutations in like PMS2 and MSS6, and it is approximately 25% of all endometrial cancer. And third one is the copy number low. This is the most common type of cancer. It has not a good prognosis. There are less mutation burden than type 1 and type 2, and P53 is wild type in such type. And last one is the copy number high. This one is found in approximately 30% of cases. Here is very low mutation. P53 found mutated in approximately all cases of copy number high, and the worst prognosis. So depending upon these molecular classifications, we can also personalize the treatment of endometrial cancer. And we will also discuss about the MSI and mismatch repair deficit concept. We all know that the high Conley conserved mechanism is to restore the DNA integrity, is the DNA mismatch repair, which depends upon various type of genes. And if there is defect in these type of mechanism, then there is a accumulation of thousands of mutations, and particularly clustered of the microsatellite, and these type tumor of known as either MSI high or deficit MMR tumors. And these type of mutations are most commonly found in endometrial cancers. That's why we will focus our treatment strategy on such type of mutation burden. In previous era, the preferred chemotherapy regime for frontline high-grade tumor was paclitaxel and carboplatin, which was based upon GOG 209 trial, in which this doublet is better than, is not inferior than the triplet regime with better toxicity profile. So this is the standard treatment, paclitaxel and carboplatin. And if HER2 is positive, then we can add trastuzumab. And overall response rate is only 40 to 60%, and the overall survival was only 13 to 29 months in such type of patients. While for low-grade tumor, because these tumors are almost all are ERPR positive, so we can manage by hormonal therapy. And also such type of tumors has high PNT and PI3 kinase pathway mutations, so we can also add everolimus, and we can also add CDK4 and 6 in low-grade tumors. And in recent NCCN guideline, in opposite side, in bottom line, there are various type of targeted therapies, and these are the excitement area for endometrial cancer treatment for nowadays. And low-grade tumor has already told that the hormonal therapy is the main management. So we will discuss one by one about these type of targeted therapies. First of all, I will discuss about HER2 positive endometrial cancers. First of all, before discussing about the trial, I will like to discuss some salient features of HER2 positivity in endometrial cancer. First thing is that it is difficult to accurately define frequency of HER2 expression in uterine serous carcinoma, then the breast cancer, and estimated 20 to 30% of all patients of uterine serous carcinoma express HER2 positivity, slightly lesser in carcinosarcoma and clear cell carcinoma. Till date, there is no validated criteria available for scoring HER2 expression amplification in the gynecological malignancies. So the availability of validated criteria, we will use algorithm which was applied for the breast cancer. And next thing is that there is the high concordance between NGS and IHC in breast cancer, but this is not true for the uterine cancer. It was only 43%. It means the detection of HER2 in endometrial cancer is not as easy as in the breast cancers. And now we will discuss one randomized phase 2 trial in which they add trastuzumab to the main paclitaxel carboplatin arm and compare with the control arm in recurrent or metastatic HER2 positive endometrial breast cancers. And the result is that there is progression-free survival in chemo-naive patient was approximately 17.9 month for the paclitaxel and carboplatin with trastuzumab arm, while the pacli-carbo arm is only 9.3 months, while for the recurrent disease is 9.2 versus 6. Although this trial was criticized initially because this is an open label trial, but updated survival analysis shows that there is a very good survival benefit, especially for the chemo-naive patient. It was not reached in chemo-naive patients versus 25%, while 29.6 versus 24 months. So trastuzumab has a very good benefit in HER2 positive endometrial cancer, and we can incorporate trastuzumab in such type of patients. Now we will discuss about some anti-angiogenic therapies. We all know that the angiogenesis is an important pathway for tumor. It helps in neovascularization, as well as angiogenesis also helps make an environment with the VGFR as a tumor suppressor, and there is a very good environment for the tumor cells. So first of all, we discuss about GOG86P. In this, they will include endometrial cancer, chemo-naive with stage 3 and 4. And they will divide in 3 arms. First is the pacli-carbo with bevacizumab. Second one is the pacli-carbo with temsirolimus, and third one is the hexapipilone with carboplatin and bevacizumab. And in all, they will give 6 cycle with the maintenance with either bevacizumab or temsirolimus. And they will compare these all 3 arms with the standard arm of the pacli-carbo with GOG23209. And what they will found that complete response was approximately objective response rate was 60% in the pacli-carbo with bevacizumab. We can compare with GOG29 trial is 51%, while it was 55% for temsirolimus and approximately 52% for bevacizumab. It means there was a slightly better response with pacli-carbo and bevacizumab, but not statistically significant. But when they took the overall survival data, then they were found that with the reference rate of 22.7 months, there is a very good response in pacli-carbo and bevacizumab, which was 34 months, which was statistically significant. So bevacizumab can be added with endometrial cancers. And in subgroup analysis, what they found that the P53 mutation is in patients with the P53 mutations, bevacizumab is working very good. It means P53 can be work as a biomarker for the response for bevacizumab in endometrial cancers. And as we already discussed, that in the worst subgroup of endometrial cancer, it means the copy number low, where the P53 mutation is found in very high rate. So in this worst subgroup, we can have some hope with the aid of anti-angiogenesis. This was the AI of the AI of the bevacizumab arm. This was the same as in other groups. So the conclusion of this trial is that although the progression-free survival is not statistically significant, but the overall survival is significantly increased with the paclitaxel and bevacizumab when compared with the historical arm. And P53 as a biomarker for the response of bevacizumab in endometrial cancer. And with this, with help of this trial, we have some hope for the vast subgroup of endometrial cancer. Now, I will also discuss about some another anti-angiogenesis. In this GY012 trial, they compare Surender, Volaripariv with both of two arms, but this trial is although negative because there is only 5.5 month benefit in both arms versus 3.8 month and 2 month. But there is hope, and they will add some another arms, and we will wait for the results. And now we will discuss about some data of immunotherapy, because endometrial cancer has a very complex environment in their cancer cells, and there is high tumor infiltrating lymphocytes in endometrial cells, and the data suggests that if there is high tumor infiltrating lymphocytic infiltrations in the tumors, then there are more chances of working of immunotherapy. Second thing is that the regulatory T cells are also present in high number, and these regulatory T cells makes an environment of immunosuppression, as well as they release some cytokines, and these cytokines upregulate M2 tumor associated macrophages, and these M2 associated macrophages also make an environment of immunosuppression. It means all these mechanisms which are found in endometrial cancers make a good area for immunotherapeutic agents. Preliminary evidence of pembrolizumab activity shows activity in endometrial cancer, and there was overall response rate of approximately 71% for mismatch repair deficit non-colorectal cohorts. And we will discuss about some keynote 158 because lack of time, I will go some fast. Pembrolizumab, in this, they took approximately 26 type of solid tumors, and endometrial cancer was the most common non-colorectal cancer malignancy in this. And in this, they took patients with unresectable or metastatic cancer who cannot tolerate chemotherapy. And in this, they give pembrolizumab 200 milligram 3 weekly up to 2 years, and their primary endpoint was overall response rate. And what they found that in entire population, is the response rate is only 34.3, but in MSI high endometrial group, is response rate was approximately 60%. While in biomarker unselected is only 11.2%. And safety criteria approximately same type of side effect as in other solid tumors. And another one is the Garnet trial, in which they took dastazimab as a monotherapy, and in this they took approximately same type of patient cohort, and this is an open label trial. In this, they will first stabilize the dose, and then lastly they give dose in 500 mg 4 weekly for 3 weekly for 4 cycle, then 100 milligram for 6 weekly in cohort A and B. And cohort A is MMR deficit, while cohort B is the pro-deficit MMR endometrial cancer. And they found that in MMR deficit patients, there are a very good response, and depending upon these two, there are FDA approved indication for both of these drugs for MMR deficit patients. But in MMR proficient patients, or where there is no microsatellite instability is low, there is a very bad prognosis. Then the scientists feel that if we can aid something in immunotherapy, then we can also work on these type of patients. And there are some rationale to combine these type of endometrial cancer treatment, like immunotherapy with chemotherapy, or immunotherapy with anti-angiogenesis or PARP inhibitors. With the chemotherapy, as we all know that the chemotherapy breaks the cells, and when there is damage in DNA, then there are more mutations, and there are more mutational burden will helps to work in the immunotherapy. Second thing, they will also do some immunogenic cell death by chemotherapy, and enhance presentation of tumor specific antigen, increase T cell activation by the dendritic cells. And if we add with the anti-angiogenic therapy, then they reduce the T regulatory cells. As already we discussed, that the T regulatory cells are the cells which make immunosuppressant environment, which are good for tumor. So by reducing the T regulatory cells with the help of anti-angiogenesis, it will help to immunotherapy. They also reverse the immunosuppressive effect by the VEGF, and they also improve the T cell trafficking and increase CD8 cells and macrophages into the tumor beds. And if we add with the PARP inhibitors, they also include TLI, they enhance DNA damage and increase CD8 core cells. And there are various trials shows that there are potential synergistic effect of immunotherapy and PARP inhibitors. So there is one more trial design in which the keynote 146, in which they add one lenvatinib with the pembrolizumab, and in this they give in they make 3 cohort. One is MSI high, one is the MSI low, and another is if these results are not available, and they give lenvatinib as well as pembrolizumab, and the result shows that it was very good response in MSI high and slightly lesser response, but there is response in even in MSI low patients. And basis of these criteria, there was FDA approval of pembrolizumab plus lenvatinib even in patients with MSI low. This one is again the same type of trial, and basis of this trial, FDA approves the lenvatinib plus pembrolizumab in recurrent proficient MMR or non-MSI high endometrial cancer in July 2021. And these are the various trials which was going on. One is the dostarlimab, another one is the with the atezolizumab, another one is LEAP-1 with pembrolizumab plus lenvatinib. And in all these trials, they will compare with chemotherapy, and as well as there are maintenance. And we will agree waiting the results of these trials. And by the help of these trials, there may be chances that the immunotherapy plus chemotherapy or immunotherapy plus various type of agents can be the first line of treatment in metastatic setting. So the take-home message is that the treatment landscape for endometrial cancer is rapidly evolving. The incorporation of immunotherapeutic agents achieve objective and durable response that have clearly surpassed those historical controls. And immunotherapy is a feasible replacement for chemotherapy in patients with deficient MMR endometrial cancers. And we are eagerly waiting for the results of current phase 3 trials to incorporate immunotherapy in various type of other agents. Thank you.
Any questions from the audience? Then we can move to the panel. I invite Dr. Senthil Rajappa as moderator of the panel.
In the meantime, can I